a question for both, following what you just said. In your opinion, and you can both answer from your own point of view, of course, disagreement are welcome. Uh, what kind of attitude or skills or basic knowledge you think should have a clinicians aiming at being involved in TFP, in learning TFP?
Well, we start from the basis that a person should be genuinely interested in psychological functioning, have capacity for empathy, interest, sensitivity to psychological processes, um, uh, human understanding, warmth, interest, and on that basis be able to approach knowledge in the field, basic psychoanalytic theory that seems essential to know, at least in general terms. And from there on, there are various roads into specific knowledge of TFP. One is coming from a general training in mental health sciences, clinical psychology, psychiatry. We have been training psychiatric residents in their third year of training, postgraduate psychologists in their postgraduate PhD stages, psychiatric social workers who have had training in psychodynamic psychotherapy, psychoanalysts, and psychoanalysts have certain advantages, of course, because of the very intense long-term self-exploration they have undergone and systematic training in psychoanalytic technique. But that sometimes has the disadvantage in that they get so highly specialized in standard psychoanalysis as the only technique that they have difficulty of adjusting themselves to the treatment requirements of severely ill patients who have contraindications for psychoanalysis and have indication for psychoanalytic psychotherapy. On the other hand, there are certain psychoanalysts who are particularly well prepared for learning TFP, those with a Kleinian background, because of the very intense exploration of transference typical for that school that fits with the intense transference analysis typical for transference-focused psychotherapy. So, personal talents, different backgrounds combine. There are some people who have extraordinary talents and with very little specific training are able to develop into very good therapists. And there are other individuals, unfortunately, even with many years of training, including psychoanalytic training, don't present with the kind of flexibility that permits them to learn and do it adequately. We have trained many psychotherapists from a broad spectrum of backgrounds and are always surprised how particular training does not tell us all about individual prognosis regarding their functioning. Would you agree?
I think that's a full answer. I would just add an emphasis on the need for a combination of an appreciation of concepts and technique and certain human qualities. If someone comes to us, because we've trained people at all different levels and we're still in the process of learning about what the best training processes are. So sometimes when we go to teach to a given audience, we need to give a summary and a review, which for some people is almost not a review of basic psychodynamic concepts. Other times we've train people with psychoanalytic training. But it would seem to me that as long as someone has an adequate IQ, they get the concepts and the techniques. But there's something about the personal quality that you mentioned. And since we're talking for an Italian audience, this anecdote might fit. I was giving a training in another country, not Italy, but at the dinner where the trainees were all present, we were talking about movies. And the movie Fellini's Satyricon came up. And someone at the table said, "That's the weirdest movie I've ever seen in my life. Why would anybody be interested in that?" And I said, "I don't think she's going to be a good TFP therapist." Because you have to have an openness to the depths of the mind, to primitive processes that go in the mind. I would add that you have to be humble about the role of reason. Sometimes people, it has to do with the Freudian revolution. People who can't give up their total trust in reason and accept that there are forces in us of which we're not aware don't generally become good TFP therapists.
But one other aspect is tolerance of aggression in oneself and in others. Be able to absorb the aggression that comes as part of negative transference without getting depressed, nor withdrawing, nor giving up, nor retaliating, being able to contain it and help the patient work it through. That capacity is one feature.
Yes, perfect. Thank you. If I may add a point from the other side, from PDI, I would say that you should appreciate your way of working, because the amount of time you have been devoting in years in talking each other, in discussing and in supervising each other, I think is an unavoidable ingredient in keeping at a high level of therapeutic skills. And I think that groups abroad should learn that very well, because even after training, people must accept the fact that they should keep talking and showing what they do to peers and to colleagues, and it's a way of interminable learning.
Could I just add a support of that idea? Because the supervision group that we have on a weekly basis has been going on for 30 years, and we can't do our work without it, our work as therapists. And it once again has to do with the respect of unconscious processes in us all. If you're going to work in depth with patients, it's going to activate things within yourself of which you're sometimes not aware. So even Dr. F.Kernberg, our leader, brings in cases where he's caught sometimes in a countertransference process, if you don't mind my saying so.
Absolutely.
And it takes the help of the group. So I would encourage anyone interested in dealing and working with patients at this level to have a regular engagement with colleagues.
Thank you. That's why I brought up this point, because I think it's been so amazing, so exciting to be in New York. But for those who never went to New York and never had the possibility to attend PDI, I think it's something important to know. One last question, maybe quite relating to this one, is that a newly born international society for TFP, and just funding, and what you think of that, and what your expectations from this international society to which all of us belong.
Yeah. We have just started, and the objectives of the society are several. First of all, to provide a collegial atmosphere for all the experts on TFP in different countries, so that our groups in Canada and Chile and Mexico and Italy and Austria and Germany and Netherlands and so on have a chance to interchange experience, enrich themselves with it, stimulate themselves, share new knowledge and findings. Second, to support, and very important, support research on transference-focused psychotherapy, on the psychopathology of personality disorders, their diagnosis, their etiology, and particularly treatment. Our main emphasis at this point is to study the long-range effects of TFP, because TFP, in contrast to practically all other psychotherapeutic treatment, is geared not to improve the main symptoms for which the patient comes: anxiety, depression, impulsivity, dissociation, parasuicidal behaviors, somatization, but to improve the total personality, resolve the syndrome of identity diffusion, and permit the person to function in a more effective and gratifying ways in the main areas of life: love and sex, work and profession, social life, creativity. We are geared to modifying the personality, and as part of this, of course, improving the patient's symptoms, but doing more than that, in contrast to the findings that exist to this point, that regardless of what kind of traditional treatment these patients have received, the symptoms improve, but the personality remains impoverished. We study them 10, 20 years after treatment, and they don't establish stable relationship, don't get married, don't get promoted in work, they are isolated, there is a stunting of the personality, and we are very interested in trying to change the personality and permit a full enjoyment of life and effectiveness in life. And research on long-term effectiveness of treatment is a major goal for which we need to include patient populations, groups from various countries who have been treated under different circumstances, and so mutual help and development of major research projects and joint and collaborative research project is a second major goal. And thirdly, of course, to improve our understanding and techniques of training therapists, develop the treatment, make it more effective, permit education that is also intensive and effective, because we are aware of the important financial constraints that exist at this time all over the world in terms of psychological treatment, particularly long-term psychological treatment, so that make TFP, which is a complex treatment that requires relatively long training periods and has relatively long duration, to make it as efficient as we can. These are the major objectives of the society, and we are actively engaged with all of them.
If I could just add to that, the society represents a level or stage of development, because it's been quite remarkable how for many years there's been an informal network of colleagues in the different countries that Otto mentioned and others. And one of the reasons that the society was not formed some time ago was because Otto has a kind of a phobia of bureaucratization. And I understand that to make something sort of too laden with rules and regulations is something we all try to avoid. But there does seem to be a balance at this point, where in order to have a more even sense of what we're doing across different sites, that to have this formal group come together to improve and facilitate our communication is a good idea. And implicit in what Otto is saying is there's, in addition to our clinical work, our theoretical thinking, and our research, there's a kind of a political side to it too, because when Otto was saying that most treatments just treat the symptoms but leave the person in a subjective sense of despair often, or demoralization, or depression, anxiety. Unfortunately, often the systems within which we work care only about having the symptoms go away so the person stops coming to the emergency room and doesn't continue to be on the system's doorstep. People who get involved in this work tend to have a very profound appreciation for the quality of the individual's life, and that's one of the things that continues to motivate us, as Otto was saying.
I think it's perfect. I think thank you very much for having been with us.